My name's Alison and I've been living with CLL for approximately 14 years. 14 years ago, I had gone to my GP with a headache, and in that consultation, he identified that my white blood cell count had been going up over the previous couple of years. So he sent me off for a blood test. 3 days later, I was called back into the surgery, and my GP suspected that I may have had leukemia and gave me a referral to a hematologist. I thought it was odd at that stage because I thought if you had cancer, you saw an oncologist. So I was about to undergo a very big learning journey. It took several months to see the hematologist, and once I was able to see my hematologist, it took then nearly a year before I was given the diagnosis. In that year, there was lots of testing, things like PET scans, CT scans, bone marrow tests, lots and lots of blood tests, just to understand the type of leukemia that I had and how it was progressing. When I was diagnosed with CLL, I understood that it was an indolent cancer, so it was very slow growing. And it was for many, many years. It was just watch and wait. And sometimes it felt like watch and worry because you'd have a test done and you think, oh, what's changed? I would identify that lymph nodes in my neck, my armpit, my groin, my abdomen were starting to develop. And I started to get, a few night sweats here and there. And it was just a matter of tracking them. The biggest thing is dealing with uncertainty, and that was the biggest challenge. So I had to make some lifestyle changes. That was a challenge when you have to make some changes in your life. The things that I do to try and make sure that I'm dealing with uncertainty and building resilience is, things like meditation, yoga, those nice activities that I like to do, swimming, have all helped me make sure that I'm on track and that I'm doing well. Things for me changed approximately 2 years ago. My lymph nodes started to grow quite rapidly and my white blood cell counts were going up quite dramatically. And then about 8 months ago, we identified that the white cell counts were getting quite high, the lymphocytes, and we started talking about, well, it's getting close to treatment. And I always thought in those 14 years that I may never need treatment, and the time had come. So that was a journey in itself, understanding that, you're about to undergo treatment and you hear all these disaster stories. And again, you're dealing a lot with mental challenges, emotional challenges. And again, it was a lot of meditation, just making sure that I was taking care of myself and, linking in with my psychologist who helped me, through those challenging times. When treatment started, I was very nervous, and everyone is when they first start treatment, but it was very gentle. I was quite surprised, and I'm halfway through. I'm 6 months. I've been on venetoclax, which is a tablet, and I had 6 months of chemo, which was staggered over the 6 months, and I'm tracking really, really well. I've responded so well. Again, though, during that time period, there was a lot of uncertainty, a lot of testing that was had taken, just to make sure that, I didn't get tumor lysis syndrome because of the dramatic waste of cancer cells being removed from the body and the impact it would have. And just making sure that, everything was going well. It's been a challenge, but also it's been a great learning journey. I've met some wonderful people throughout that journey, and so far I'm doing so well. I'm really happy with how I'm tracking.
Hi, my name's Sharon, and I am going to tell you about my CLL, SLL journey that I've been on, because it is definitely a journey. I was diagnosed in end of October 2020. I had a virus for a couple of months, couldn't get rid of it. Woke up one morning, they'd done lots of tests, everything seemed fine. Woke up one morning with a lump out the side of my neck. My hematologist doesn't believe that it came up that quickly, but it actually did. And got up in the morning, I showed my husband, look at this. And he goes, oh, that doesn't look good. Went to work, look at this came up this morning. They said, oh, that can't be good. So, trying to get back in a doctor, very difficult up here because we're in a rural town north of Cairns. Anyway, so they did more tests. Still couldn't find anything. They said, "Oh, we'll send you away for a ultrasound. Send you up to the hospital at our hospital for an ultrasound." Okay, went and did that. So the guy just did an ultrasound of my neck. He said, "Oh, have you had a virus?" Yes. And he said the same thing that the doctors had been saying. "Oh, it's probably just your body's immune response and trying to get rid of the virus." Okay, so it didn't really tell us anything. So then they went back to the doctor. They said, "I'd leave it for a bit, see how it goes, and, come back if it's still like that in a month." So in a month, it's still like that. So I go back to the doctor and they did more tests and found out all these things I don't have. And then they said, "Oh, we might send you to Cairns for a biopsy." So I went down to Cairns, which is about an hour and a quarter away. And then they, when I was there, the doctor or nurses, whatever, I'm not sure what their role is, but they did, they said, "Oh, look, there's two kinds of biopsies that you can do. There's the small one that they've asked you to get done, and there's a core biopsy." And I'm lying there thinking, "Well, I'm glad I'm not having the big one." And so then he did the little one, and then he said, "Did you get an ultrasound done?" "Yes, got the ultrasound done at Mossman Hospital." He said, "Oh, we haven't got it yet, so haven't got the results. Would you mind if we did an ultrasound here?" I said, "Yeah, that's fine." So he did an ultrasound, and he said, "Look, all of your lymph nodes look swollen." He did my whole body, not just my neck, which is what the Mossman Hospital did. And he said, "We might do a core biopsy, seeing you've come all this way." By which time I'm starting to panic a little bit. So he rang my doctor and then, yeah, that's okay. So they did the core biopsy. And then he's saying, "Look, you've come all this way, why don't we do a CT scan?" So I am really starting to panic at this point. Did the CT scan, and then I may have just been reading into things, but I could just tell something was wrong by the people who were there. Something wasn't right. So then my husband and I drove back home, got a bottle of wine at the bottle on the way, and went and sat on the beach and tried to process what we'd just, been through, because at that point you don't have any answers whatsoever. You just have all of these what ifs and I wonder why and all of these things. But in the back of my head is still, I'm way too healthy to have cancer, which is obviously what you're starting to think of at that point. So no, I'm really healthy, apart from this virus and this weird lump in my neck. Eat healthy, exercise all the time, and trying to reason with your own brain. Anyway, the doctors down there said, "Oh, you should get the results back on Friday." So when I got home, I organised to get a doctor's appointment on the Friday. I tried to, and they said, we're in a rural town, so it's really hard to get appointments. And it was in the middle of COVID as well. And they said, no, we can't get you in. We'll give you a phone one in 2 weeks' time. Yep, okay, no worries. So went to work on the Thursday, trying not to think about it. And our principal was away at the time, so I was basically running the school. And then on the Friday, we had our swimming carnival. So when you go swimming carnival, you're in the pool and in and out, etc. So I'd left my phone in the car. Anyway, at about 2:45, I said, "Look, I'll run the bus. The kids who need to catch a bus, I'll run them into back to school from the pool." So I got in my car and there's all these missed calls on my phone from the doctors, including a verbal message saying, "Oh, the doctor really wants to talk to you about your results. We want you to come in today at 3:00. So I'm panicking at this point and didn't even think to ring my husband to meet me there. I just go, okay, got to get to the doctors. So got myself to the doctors, and that's when the doctor gave me my diagnosis. She said, "Your results have come back that you've got lymphoma, which is a type of cancer." And I'm going, "What do you mean? I can't possibly have cancer. I'm too healthy." And I don't remember process. I don't know. I just sat there gobsmacked. I think I just didn't know what to think. So it's kind of wishing I'd rung my husband at that point. But anyway, so she rang my GP, rang the haematologist while I was there, and spoke to her, and she'd said, so all I knew at that point was that it was a B-cell lymphoma and that it was indolent, so it wasn't particularly aggressive, which sounded okay. If you were going to get a cancer of some form, that sounded like one that was not as bad. And then you think like that then. Anyway, I think I did know at that. No, I don't think I even knew if it was Hodgkin's or non-Hodgkin's. I can't remember at that point. Anyway, so then went home, kind of freaked out a little bit with my husband, and biggest thing I was worried about was having to tell everybody, I think. So I made him do that. He told all the kids and my family, and then went and saw the haematologist. I think it was only a week or 2 weeks later, and then she did more tests. So she did the PET scan and she did a bone marrow biopsy, and that's when they knew that I had, which they said SLL first, and then after the bone marrow biopsy, she said CLL/SLL. So I wasn't sure what that meant at the time. And she talked about treatment options. So that would have been in middle of November. And her advice was she gave me options, but I don't know, I'm taking her advice. So she said, because it was such a large lump and, I was panicking about it getting bigger and, things like that. Anyway, so she thought we'd do treatment straight away. Because I had other symptoms too. I was really tired, though I just thought that was a natural state of being in our job. And I had lost weight. I had a few other symptoms and things. So she said, we'll start bendamustine and rituximab. And I started the day before Christmas Eve in 2020. And as I said, we live an hour and a quarter away, so I had to drive down got a PIC line in, so and then had the first treatment that day before Christmas Eve. Had it over 2 days, so both treatments felt fine on the 2 days. They pumped me full of steroids, which I actually hated more than the treatment, I think. So then because you can't sleep and you're really wired, and then after the treatment was okay for probably the 2 days that you're on the steroids, apart from the fact that I couldn't sleep. And then the big crash, so I felt really pretty crap for 4 days. I count it as a week, basically. It's a week of lying in the front room, in front of the TV, watching Friends reruns over and over and over, and dropping in and out of sleep, basically. And then at the end of the week, we have to drive back down to Cairns, another hour and a quarter to get a PIC line dressing. That was the hardest one because still feel pretty crap after a week. And then come back and then have a week of kind of just a down week, but not feeling too bad. And then 2 weeks of feeling fantastic because my treatments were once a month. So felt fantastic for 2 weeks. Went out, had lunches, drank wine, was running, feeling on top of the world, basically, and then mentally preparing myself for the next round. So it's a very bipolar existence, basically. You have, one really shit week, one mediocre week, 2 weeks of feeling, I feel great. I had the luxury of being able to take the whole 6 months off. My job was way too stressful. I'm around little kids who are snotty and you couldn't be immunocompromised around kids, so I just figured I'd just take the whole 6 months off to deal with the whole journey, basically. So I'm so glad that I did that. That was a real silver lining for me though, because I'd never had 6 months off. It's in the 30 odd years that I'd been teaching, apart from the 4 years I had off to have my 3 children. But then that's not really off because you're looking after children. But this was actually a whole 6 months off, so there was a real silver lining to that. Then at the end of the 6 months, which was May last year, I went back to work in mid-July. Felt amazing. Felt like I was on the biggest high I've ever experienced in my entire life for months. Really hard to explain. I think it was like this, being able to return to my version of normal and being part of something again. I was on a real high for ages. Plus, I'd had that 6 months of rest. So, yeah, that was a really amazing feeling to go back and rejoin the workforce and do the job that I love to do and just be with people. And, I really, really felt amazing. That I'm not on that high anymore. I'm back to reality now. So, but still feel great at work every day. And life has largely returned to normal, and I feel like that's just a bad dream that I went through. Even though I don't. I know that it's non-Hodgkin's lymphoma, and I know it's not curable, and one day I'll have to go through that journey again. But when that comes, that comes, and I refuse to lie in bed at night and worry about it, because I don't lie in bed worrying about being hit by a car tomorrow. I don't lie in bed worrying about having a heart attack tomorrow. I'm not going to do that. So I'm not going to worry about this either, basically, is my attitude on life. My neutrophils have bottomed out. They've never really come back since the 18 months since I had treatment. So, but no one seems particularly phased around that. So I'm not phased around it either. I do wear a mask at work all the time, so I don't pick up all the kids' germs, but yeah, that's my journey. I actually feel at the end of it, it's weird, I guess, but I actually feel really empowered that I've been on this journey. I would choose not to do it, of course, but now that I'm on the other side of it, I feel really empowered that I've done it. I'd love to be able to help anyone else going on this journey and be there for anyone who needs someone to be there, because it's a pretty amazing journey. It's a huge mental journey more than anything, in my opinion. So yeah, good luck. You can do it too. Bye.
So I'd firstly like to thank Kathy and Alison and Sharon for sharing their stories. I think living the day-to-day with a CLL or an SLL can be one thing, but to put your experience into writing or video is entirely different, and it takes a lot to share it publicly, so I thank you for that. It's obvious from all three ladies that even though they've had different treatments, they all face similar struggles emotionally and mentally. So thank you for sharing. I wanted to launch a quick poll with a couple of questions. The first question asks, are you aware of your CLL or SLL mutation status? And the second question is, was there an out-of-pocket cost for your mutation testing? So if you just pop on your screen, it should have popped up. I'll just give it half a minute if you can answer that for me. Wow. Lots of different answers coming through. It looks like about half have. It's pretty an even split between yes and no. And I can see that a couple have had to pay for it. I'll leave that open for a little minute. But these questions are significant because it is known that certain mutations won't respond to conventional chemotherapy. And that is why these new novel agents are up for recommendations against the PVAC. They're so important for what we do. So today's webinar is actually timely, as it's not just World CLL Day, but there is an upcoming PVAC meeting and agenda. The agenda consists of 2 important CLL protocols. So the first protocol being considered for public funding is ibrutinib, which has been available for several years as a once-a-day tablet for people with relapsed CLL or SLL, or as compassionate access. But this is now being combined with another oral treatment called venetoclax. This new combination treatment is taken orally once a day for 15 months only. The second protocol is acalabrutinib in combination with obinutuzumab for people with newly diagnosed or untreated CLL, SLL who are considered unsuitable for a fludarabine-based chemotherapy. So I'll want to play another quick video for you. It's only a minute. So I'll quickly put that up for you. Sorry, guys, I think there might have just been a problem with that sound. I'll quickly try that again. Sorry for the technical. Try one more time. Sorry, guys. I think the sound just didn't work on that one. It's just some beautiful music, but if you'd like to hear that, you can go to our website. The video is there. So I'd like to now just introduce Erica quickly. So Erica is our National Nurse Manager of Lymphoma Australia, and she was going to just discuss with me the PBAC or PBS and PBAC submissions and how it works. So hello, Erica. Thank you for joining.
Hi, Lise.
Let me just make sure. I'm just going to take my spotlight off so everyone can see you and me. There we go. So can you briefly explain how medicines get subsidised in Australia?
Yeah, absolutely. So medicines in Australia are registered with the Therapeutics Goods Administration. So that means that they're safe and effective for use in Australia. But to be able to have subsidised access to them, because these medications cost a lot of money, they need to be listed onto the PBS. And so for a medication to be listed onto the PBS, they first go through an independent advisory committee that consists of health economists and other health professionals, and also consumer representatives as well. And when it goes through this committee, it's called PBAC. And so for a medication to be listed on the PBS, they need a positive recommendation at that PBAC meeting. And so that's why it's so timely, as you've said, that these two medications are coming up very, very shortly for recommendation onto the PBS. So it's really timely for consumers like yourself, so anyone who has been touched by CLL, to then actually submit consumer comments to then support these initiatives and these medications going forwards. Because without your voice and sharing your experience, medications like this may not be funded. So sharing that experience is really powerful. So there's actually information on how you can submit your consumer comments to ensure that they are considered and are considered for endorsement on the PBS. So to access this information, you can actually hop onto our website, onto Lymphoma Australia's website, and if you search CLL, you'll find all the information there with a lot of frequently asked questions and instructions on then how to be able to submit a meaningful consumer comment to ensure that it's actually supported. So does that answer your question?
That answers my question perfectly. And you then went on to the next one. So yeah, people can go to our website and submit their comments if they'd like to. I'll also send the link out tomorrow. So once this recording is finished, I'll try and get it out for people to be able to watch back again. And I'll put the link in there as well for everybody. So that definitely answers my question. Thank you so much, Erica. I appreciate that.
Thanks, Lisa.
Okay, I think that we have Con here with us now. If I can get...
You need to start my video.
Hi, Con. Thank you.
Hi. I can't start my video because the host has stopped it.
Oh, have I? Just try and fix that for you. I don't know I'll just make you co-host with me then.
Okay, great.
There we go. Hello, thank you.
The power.
Technical difficulties. Hi, thank you
Hi, how
so
are
much
you?
for joining us today on this significant day for CLL and SLL, World CLL Day. What I might do is briefly introduce you and then I can get stuck into some questions. Is that all right with you?
Absolutely.
Hi. Okay, so Professor Con Tam is Head of Lymphoma Service at Alfred Health and Professor of Hematology at Monash University. Prior to moving to the Alfred, Con served as disease group lead for low-grade lymphoma and CLL at Peter MacCallum Cancer Centre and Royal Melbourne Hospital for over 10 years. So he's passionate about developing new treatments for blood cancers. He is the global lead for the BTK inhibitor zanubrutinib and oversaw its development from the first human dosed to successful international licensing studies worldwide. Con designed and performed the first global study to combine ibrutinib and venetoclax, and his involvement in this clinical trial has the potential to change standard of care for CLL in Australia in previously untreated patients. And in 2015, he also became the Australian lead for the pivotal study of the tisagenlecleucel, I knew I'd get that wrong, in diffuse large B-cell lymphoma, leading to public funding for CAR T cells as standard treatment in Australia. So a very dedicated to career so far to lymphoma, and what I can imagine he has more planned. So we're so glad you could join us here today, Con. Thank you so much.
Thank you. It's a real pleasure, and I didn't realize there's even a World CLL Day, so I'm very, very happy to learn about this fact.
There is a World CLL Day. It happens every year, so I'm so glad you could come, and our patients are really interested to hear what you have to say.
Absolutely. Now, question and answer question, is that right?
Yeah, we'll just do it as a question answer if that's okay with you, and we'll keep
good.
it. And I have a few questions at the end from patients who have sent them through beforehand, and I'm sure throughout the chat, I think people, again, if you want to ask a question, there's a chat function, a Q&A function at the bottom of the screen. So I think with CLL and SLL, it's really important to start at the beginning. Okay, Con, a new patient comes to you from their GP. What diagnostic tests do you perform on them when you suspect CLL or SLL?
Sure. So most patients actually come to me these days with an accidental diagnosis. So they will go for a blood test for another reason, like a general health check, and will be found to have a high white cell count on the blood test, and then the GP will send them to me. Now, the good thing about CLL is that it's something that we can assess very simply with blood tests and a clinical examination. So no fancy scans or bone marrows involved in most patients. So obviously we'll ask you about your symptoms. Have you got any tiredness? Have you lost weight? Have you had a lot of infections? We'll examine you to see if your lymph glands are large and whether your liver and spleen are larger than normal. And then we do a blood test, which will include a standard blood count, a standard check of the kidneys and your liver, and also a test called flow cytometry, which is where we get a machine to look at the white cells in the blood and to tell us what the white cells are, what the different types are. And the good thing about CLL is that in over 90% of patients, the flow cytometry shows a very characteristic pattern. So we can come back to you at the next visit and say confidently that you've got CLL, And then we can also give you a stage based on your examination and your full blood test. And that's probably the extent of the evaluation required for most patients who otherwise have no symptoms and are in early stage CLL.
Okay. And are all of these tests available for everyone in Australia?
Yes, so this is a very simple test. So there's a doctor's examination and a full blood count, and flow cytometry is available even in the remotest areas of Australia.
Excellent. And should mutation testing be done?
Yeah, that's a really big question. So these days, when I first started CLL maybe 25 years ago, there was only one disease. And now we understand CLL by the mutational profile. So there are probably two main mutational profiles we talk about. So the first one is what the IGVH mutation profile is. And this is a bit of a confusing topic because you get either mutated or unmutated. And paradoxically, in life, if you actually mutated in IGVH, you actually have a better prognosis and you do better in the long term than people with an unmutated IGVH. So probably around 60% of patients who are newly diagnosed would be mutated with a better prognosis, and then about 40% will be unmutated probably at the time of diagnosis. Now, the other set of mutation testing relates to genetic abnormalities within the leukemia, and they can be tested in several ways. So the most traditional way is to do something called a FISH test, which is a set of probes to see what genes the leukemia has deleted or gained. And then there's an additional test, which is called next generation sequencing, which actually looks for spelling mistakes within those genes. So there are two separate tests, but the purpose of the second set of tests is to see if people carry a mutation or deletion in a gene called P53, which is a really important gene for chemotherapy response. And people with P53 deletion or mutation, where the P53 gene doesn't work. And some of you may have heard of this because we otherwise call this a 17p deleted CLL. They don't respond well to chemotherapy. Now, the question is, should you be doing those tests at the time of diagnosis? And the answer is they're not really necessary. So, because the proof is in the pudding. So the most important thing to determine how well you do with CLL is how well you do in the next 6 to 12 months. So if your blood counts remain stable, you remain well, the lymph glands remain small, then you've got a good outcome and a benign behaving CLL. On the other hand, your blood counts continue to go up and up and up, and you start to get symptoms, then obviously you've got a more aggressive form of CLL. And that in itself is actually more useful than any mutational testing. And I think the mutational testing is really required at the time before someone starts treatment. So if someone gets followed for a number of years and then comes to a point where they require treatment, then it's crucial to know what the mutation testing is at that time. Before then, it's something that's nice to know, but it doesn't give us, it's not necessary.
It's interesting. We just did a poll on the patients, and it was 50% or 57% of patients who were aware of their mutation data. So I wonder then too, maybe I should have asked if they were the patients who have had it prior to starting treatment, or if they had it at the beginning. Very interesting. So you would do this genetic testing before starting treatment. Is it a standard for most CLL, and does everybody have access to that?
Yeah, that's the other thing, and it's very frustrating because we know these tests are important and we know they help our decision making, but probably until the next year, the last year or two, we haven't really had good access to them. So at Peter MacCallum or the Alfred, a big hospital, yeah, we can get these tests done pretty easily. But if you're like in a different state, so Victoria seems to have unusually good access to these tests, but even a different state or even in a rural location, they can be quite difficult. But my understanding is that these days, if your doctor does request a mutation testing and a FISH test on a blood form that you take to a standard major pathology company, even at the furthest reach of Australia, the blood collector may look a little bit confused at you when they look at the form, but they will ultimately get the right test done. So, these tests do take many, many months to come back. So, don't expect a result overnight.
Yeah. Just on average, what is the average time it does take to come back?
Oh, I would say, like if the patient's at Peter Mac and I send it off and I know it gets done at Peter Mac, maybe 6 to 8 weeks.
Yeah. Wow. And is there a cost with that test?
So The fish testing is funded now in most places by the public system. In most places, the sequencing test is still not. So the sequencing test, there is a cost. At least in Victoria, we have got access to the sequencing and the fish test because of a generous donation. But there's been a generous donation that's been made to Peter Mac to test patients with CLL for free in Victoria.
Do you know the cost for somebody in, say, another state or a regional area just to get that done?
I would say approximately $500 for the sequencing test, and the fish test, like I said, should be covered.
Yeah. Okay. Sometimes that's a bit of money for these patients who are a little bit stressed, but
Absolutely,
okay.
absolutely.
So, okay, can you then explain the difference? So this might be a bit controversial, but what is the difference between a CLL and an SLL?
Yeah, it's actually exactly the same thing. So CLL and SLL is exactly the same disease. If you take these two diseases apart and you look at the cells and you look at the genetics, they're exactly the same. They respond exactly the same to treatment. The difference is how they present. So CLL cells are less sticky, so they don't stick to the lymph glands as much as SLL cells. And SLL cells is just a cousin of CLL, where the cells are especially sticky. So they stick to the lymph glands in the bone marrow and they don't circulate very much. So in CLL, we usually see it first in the blood because it just circulates. But in SLL, which is approximately 5 to 10% of patients with CLL, because the cells are sticky, the lymph glands tend to grow and accumulate disease before we even realize it's there. And when we test the blood, often there is not much disease in the blood. So the people with SLL tend to get recognized a little bit later than people with CLL, but otherwise they do exactly the same. And it's confusing because probably until the last 10 or 15 or 20 years, we had no idea they were the same disease. And one disease was managed by one group of doctors and the other group disease is managed by another group, which is why if you look at the SLL literature, you'll see that some of them are actually managed and staged like non-Hodgkin's lymphoma, when really they should be treated like CLL in this day and age.
So that's only been the last, what you say, 10, 15 years that they've been doing that?
Probably, yes.
And is CLL a leukemia?
Absolutely. So the last one in CLL actually is leukemia. So it's chronic lymphocytic leukemia. Now, of course, leukemia comes in many different forms, and leukemia is a really frightening word, okay? But just like lymphomas, you've got forms of leukemia that are very fast-growing, very aggressive, very dangerous. And then you got forms of leukemia which are very slow-growing. And, as you know, people with CLL, there's about 50% chance that people with CLL will die of old age and never be treated for the leukemia. That's how growth slows. So how slow it grows. So the chronic word in CLL, and a lot of people don't understand what chronic means. They think chronic means bad because you hear it in the news all the time. But chronic actually means slow. So chronic lymphocytic leukemia means a leukemia that grows slowly and is made up of lymphocytes, which is the cells that the CLL cells are derived from.
Okay. So does the WHO classify it as a leukemia or lymphoma though?
That's a really good question. I didn't look at the WHO book and have a look. It's a lymphoid disease, but it should be classified as a.
And I think we class it as lymphoma too, because we're Lymphoma Australia. So
Sure.
And then we have quite a community of lymphoma CLL patients, and we technically call it a lymphoma.
Yeah.
But yeah. Okay, so let's move on to treatments for the CLL and SLL. And obviously these are so different from person to person. So can you explain to me what's currently available for the different treatment options for someone with CLL?
Yep. So we're probably transitioning into an age of chemotherapy to the new agents, the new targeted drug, which are not chemotherapy. So our emerging most patients will hopefully have an understanding about how they differ. So chemotherapy drugs damage the genetics of the leukemia, and they work because they also damage the genetics of your body. And the way they work is because your body can repair genetic damage better than leukemia can. So therefore, you end up killing off and damaging the leukemia cells more than it damages you. But chemotherapy is kind of dirty. I mean, they work really well, but it's kind of dirty because it damages all the cells in your body. And the other drugs, which are non-chemotherapy drugs, are what we call targeted agents. And they differ in that the targeted agents specifically knock out genes within the cancer that the cancer depends on. So these are genes that typically the cancers really need to survive, but the rest of the body doesn't really need it. And because you're targeting the gene that is important for the cancer, but not for your normal body, they tend to have far fewer side effects. So that's how they differ. Now, probably until I would say about a year and a half ago, our only first treatment option that's funded by a public system is chemotherapy. And they probably come in 3 flavors. Okay, so if you've ever been to like Nando's and you look at which is a chicken chain, and they have different sauces you can get. You can get the very hot sauce, you can get the mild sauce, and then you can get the lemon and herb sauce. So there are 3 real categories of chemotherapy intensity in this country. So there is a chemotherapy called FCR, which is called fludarabine, cyclophosphamide, and rituximab, which is the very hot sauce. And then there's one which is called medium, which is bendamustine rituximab. And then there's one called obinutuzumab plus chlorambucil, which are probably the 3 different flavors of chemotherapy that you can get. And obviously, the hotter the chemotherapy, the better it works, but potentially the higher the side effect risk. So let's say FCR, we tend to not give to patients over the age of somewhere between 65 and 70. Some patients are very fit and can take it. Bendamustine, maybe somewhere around 65 to 75. You know, if you have got a bit of heart problem, a bit of kidney problem, that might be the medium source. And then if someone's got a bit older, let's say over 75 or 80, have a lot of other issues, and we don't want to want to minimize the side effects, we would give the lower intensity chemotherapy. They all work, but obviously the hotter the chemotherapy, the longer the responses. So, you might get a response of 2 to 3 years for the lowest intensity, or responses of 7 or 10 years for the highest intensity chemotherapy. So like I said, until recently, we've only got those 3 flavors. That's chemotherapy in this country. As of, I think about 2 years ago, we have our first targeted agent to be used frontline, and that's a drug called venetoclax. It's a tablet used in combination with an antibody called obinutuzumab. And this is suited for people who are not fit for the standard chemotherapy. So the people who took the bendamustine rituximab, so the medium and the low flavor chemotherapy before has now been replaced by targeted agent, whereas the hottest chemotherapy, there's still no targeted agent possible in that group, at least in the first line. Our first line chemotherapy, the first chemotherapy that you get for your leukemia. Now, if it comes back after you've had chemotherapy and needs to be retreated, then we've got a number of targeted drugs which are funded. And the 2 major classes of targeted drugs, there are actually 3, but we only really use 2 of them. One's called BTK inhibitor, and one's called BCL2 inhibitor, of which venetoclax is a member of the class.
I must say, I don't think I've ever heard chemotherapy regimes as hot sauce and leveled them in different levels of hotness, but that's actually a very good way for a lot of patients to understand it. Now, you say that the FCR is the hottest and most toxic, I suppose, to patients. Do this toxic top-tier treatment, does that leave a lot of long-term effects for patients? Yeah,
so FCR, with everything in life, the more toxic a treatment is, the better the cancer response. So, for the patient who's fit enough, we try and give the most effective, which means often the most toxic treatment possible, if the patient is otherwise able to take it. Now, even FCR chemotherapy is actually not that toxic. You don't lose your hair. There's about 1 in 6 chance of infection. Most people work into a normal life during FCR chemotherapy. They don't have to, take time off and just, put their life on hold. With FCR chemotherapy, the major side effects are nausea. So these days we give tablets to control nausea, and the tablets work so well that in fact, the major complaint I get from my patients is not nausea, but constipation from those tablets because they work so well. And also FCR, as with any chemotherapy, is associated with a risk of infection. Now, the long-term side effects of these chemotherapies are an increased risk in second cancers. So second cancers means that even if you have been successfully treated for your current disease, which is CLL or SLL, that in 5, 10, 15 years time, you might get another cancer like lung cancer, bowel cancer, bone marrow cancer. And these things happen for several reasons. So firstly, normal people get cancers anyway. Secondly, if you've had one cancer, you're more likely to get another cancer. But lastly, if you remember that I said the chemotherapy damages the genetics of all your cells in your body, well, some of those cells don't repair the genetic damage perfectly, and that can lead to another cancer in the long term. So we know that after FCR chemotherapy, that about 3% of patients, that's 1 in 30, will get a bone marrow cancer called myelodysplasia, which can be a fairly awful occurrence if it happens. Now, that would probably also happen with the lower intensity chemotherapies, but to a slightly lesser extent. And for targeted therapy, where you don't damage the genetics of your normal cells, that risk is basically non-existent.
So the mutation testing, some of it will show that these patients won't respond or do very well with traditional chemotherapy. So for those patients, I suppose that's the significance of doing the mutation testing to start with before they're starting treatment. And do you then opt? I mean, obviously, you would try to then opt not to do FCR. Are there a certain number of patients that you still go for the FCR, even if it's not any good?
So I would say that, about 1 in 10 patients will have, at the time of treatment, mutation testing that shows that they're not going to respond well to chemotherapy. Now, for those patients, I would try like mad to not give them chemotherapy if I can. You get lucky sometimes and people do respond to chemotherapy, but you know that you're more than likely to fail. And really, you should probably not subject your patient to chemotherapy side effects, even though it's not going to work, or if you think the chance of working is low. Luckily, the targeted agent, obinutuzumab venetoclax, this is the new regimen that replaced the medium and the lowest intensity of the chemotherapy, that is effective against the mutated CLL. So those patients can now go straight onto the new agent and know that they will still respond well on standard PBS funded therapy. The most difficult group are people who the PBS has not funded the new therapy for, because they are quite fit and they're fit enough to take FCR chemotherapy. And at this point in time, there's still no recognition that patients who are FCR fit, who have a 17p or p3 mutation, where we know the chance of working is not high, there's still no real good access in the public system for a targeted agent for those patients, which is where often why these patients will be referred, let's say, to myself or to a major center for clinical trial, because often we can have access to novel agents that we know is going to work in that setting for 17p patients, and they don't have to, go through the gauntlet of having chemotherapy and not responding before going on these drugs. The problem, of course, for patients in rural location is that it's quite a big deal to travel to a big center or big city to go on a trial and to come back for follow-up. So it's quite a commitment. And it's a gap in our system at the moment that we don't have public funding for targeted agents in the FCR fit population.
It's definitely a gap, and it's something I suppose that we're a bit passionate about, and getting those treatments available to people in all areas. I mean, it's great that you have these clinical trials in the hospitals that you're at, but that doesn't actually help the patients sometimes when they're out in those rural areas and they don't want to leave their jobs or their families, and that's really hard. But also I think too, they think that it's a tablet, so it's just easy and they can just go home and take a tablet and they'll be fine, and that's not the case either, is it? It's more than just taking a tablet.
Correct. So, I mean, yes, there are tablets. Yes, once they get working, they're very easy. They're very easy to take. But often, especially with venetoclax, there's a lot of fiddling in the first 1 or 2 months to get the tablet up to the right dose, and a lot of visits to doctors, which is often not possible in a rural setting. And if you are getting a new drug, a drug where it's not fully licensed to be used prescribed just yet. Well, I mean, we need to monitor people carefully, and that monitoring needs to be done at a major center. So people often take tablets, they feel really well, but they still have to come back every 3 months for a checkup, blood test, scans, and it's very frustrating when you feel well and you have no side effects of any to speak of.
It is hard. But these tablets and these new ones coming through, they don't come without their side effects. What are some of their side effects?
So some of you will be, so let's talk about the two major classes that we use, okay? So we've got a class called BTK inhibitors, of which the most commonly used drug, the first generation drug, is a drug called ibrutinib. And ibrutinib is a drug that I know really well because, like, we first saw the results presented at an international conference in 2011, and our jaws dropped when we saw the results of ibrutinib. So we went up to the podium, and she said, there was Stephen Mulligan and myself went up to the podium and said to them that we have to get this drug in Australia. How can we join your clinical trials? So we've been using ibrutinib since 2012, really. And it's a great drug. It saved many, many of our patients. And the side effects are, in general, extremely mild compared to chemotherapy. But there are probably two main major groups of side effects of ibrutinib that are unique to the drug. Firstly, ibrutinib causes bleeding. It causes the cells in your body called platelets to not stick together. And that is just the way the drug works. So bleeding is a risk, and it's just like people taking aspirin and people taking Plavix after the heart surgery. You would take ibrutinib, you would get more bruising, you notice more bleeding. But the most important thing and the most troublesome thing is when surgeons try to go and do operations on my patients, because the surgeons do not recognize ibrutinib for what it is. The surgeons know what Plavix is, they know what aspirin is, they don't know what ibrutinib is. So they forget to stop the medication, and then they operate on my patient, and then the patients bleed and bleed and bleed. So the most important thing about starting a drug like ibrutinib is the patient needs to remember that the drug causes bleeding, and if they have any surgery, they need to let the surgeon know and let the doctor who prescribe it know. When we stop the drug, you can have surgery successfully. There's no issues. The second major side effect of ibrutinib is arrhythmia of the heart, where the heart can go out of rhythm. It's called atrial fibrillation, and it's very common in older people anyway, as in people who are just normal older people without leukemia and not on drug therapy. But the risk of atrial fibrillation definitely goes up with ibrutinib. There's now second generation drugs. So there's a drug called acalabrutinib and a second generation drug called zanubrutinib, where the risk of atrial fibrillation and bleeding is lower than ibrutinib. So we've got better versions of these drugs already. So that's BTK inhibitors. Now, the other group of drugs that I talk about are the drug known as venetoclax, which inhibits a protein called BCL2. They're a different group of drugs. And there are now other members of the drug coming up as well. But venetoclax and all its friends, the big issue with them is that they work too well. So venetoclax is too powerful. And if you start the full dose of venetoclax on someone without any preparation, it can destroy kilograms of cancer overnight, which sounds really good, except when you destroy kilograms of cancer overnight, you end up poisoning your blood because the cells burst and they release toxic chemicals into your bloodstream, and it's something called tumor lysis syndrome, which people can actually die from. So when you use a drug like venetoclax, you need to learn to control the beast. So we start off at a really low dose, and we monitor for we monitor to make sure we don't kill off too many cells, and then we increase the dose bit by bit on a weekly basis, and we get lots of blood tests. Now, you mentioned before that sometimes patients don't understand why starting a tablet, you have to be so complicated. It should be easy to start a tablet. And venetoclax is a really easy drug to take. You just take a tablet and swallow it. It's got hardly any side effects, except it works too well. So in that 5-week ramp-up period, when we gradually increase the dose, we need to check the blood test frequently to make sure that we're not killing off too many cells. And some of those blood tests happen in the late afternoon, let's say 4 or 5 p.m., and we need the results back in real time. So we need the results back within an hour. If you live in a country location where the pathology courier comes around and picks up the blood twice a day and takes it to a city 4 hours away to analyze, and we don't get the results for 2 days, well, that's not going to work, because by the time we get the result coming back showing that something's in trouble, you're already,
You're already too late.
it's already too late, which is why venetoclax, you need to have real-time pathology, and it needs to be done typically in a big city or somewhere where you can have a blood test performed on the spot, have the results on the spot, and then have it acted on if there's anything wrong.
And I suppose that's why we see patients coming into hospitals, maybe for the first week of starting venetoclax. Sometimes I think I've seen it done as an outpatient, but most of the time for us, I think the patients get seen, well, they get brought into the hospital and they get ramped up over that week period, and then they often can go back to where they are, and it's not as severe depending on how their tumor lysis goes.
Yeah.
All right. Sorry, I've gone off track with some of my questions. So I think we've slightly touched on it, but what makes someone unsuitable for chemo and then eligible for venetoclax as per the PBS guidelines?
So the PBS guideline uses the two criteria for why you're unfit for FCR chemotherapy. The first one uses a score called a cumulative illness rating scale, or CIRS score, and that's a score of a patient's other medical problems. So, for example, you've got high blood pressure, you've got heart disease, or you've got stroke, or you've had a major cancer in the past, you've got lung problems. Each of those things give you a certain score from 1 to 4, depending on whether it's just a minor problem or depending on whether it's a major life-threatening problem. Now, if you have, when you add up all your different organs and all your different medical problems, if your score gets above 6, which in my mind is probably someone who is, let's say, on 3 or 4 medications for heart or blood pressure and other things, then that's deemed to be not fit for FCR, and you can get access to venetoclax or inotuzumab. The other way to get it is a kidney function, showing that your kidney function works at about the 2/3 of a normal person. So as we get older, our kidney function does deteriorate, and as we have other medical issues, our kidney function does go down. And if you've lost roughly about 1/3 of your kidney function, as shown on the blood test, then that is thought to be not fit for FCR chemotherapy, and you can potentially get this treatment.
So we were talking before you came on about the PBAC recommendations for the new ones coming to the front line for these patients.
Yeah.
So why would it not get approved in a frontline medication?
So the biggest issue is cost effectiveness.
Yeah.
If you're young, as in less than 70, and you're fit and you get FCR chemotherapy, depending on what your RGVH mutational configuration is, you might get 4 or 5 years of remission on the one hand. On the other hand, you might get 10 years of remission. So you're talking about years and years of remission here, which is a really good outcome for most patients. And the PBAC will look at that and go, well, look, if you give chemotherapy, and you get years of remission without having to treat it again, or you can fund a tablet, which on the commercial price is around $150,000 to $200,000 a year, and you have to fund this tablet ongoing for years and years and years. Is the cost of the tablet worth the outcome, given the chemotherapy is already so good? Which is why, and I think, I can see the point of view. If you have a limited budget, which we all live with because we're all taxpayers, and these medicines are expensive, we give them to people where they don't have good treatment options. They don't get years of remission with chemotherapy, or they can't take chemotherapy. So we fund those medications for those patients first. And then as the evidence gathers and as the drug prices drop, then we can start to look towards people where, who have got good outcomes with chemotherapy, but where we think that these tablets are probably incrementally better, but not as much of a game changer as someone where chemotherapy doesn't work or chemotherapy is unsuitable.
Okay. All right. So I wanted to check, I suppose it's hard because these drugs are, I don't know, is it beneficial for the patients to really have the chemo if they could have these tablets?
I think patients need to have the treatment when they need to be treated. So some patients can be watched, and some, and we don't recommend that people start treatment unless they really need to. But if you need to start treatment, you need to start treatment, and you need to get whatever you can get at that time. And chemotherapy still works well. It's got a proven track record. It works well. It's a bit like, do you like to you want to have the Toyota Camry, which is 25 years old, but we know how it works, we know it's reliable, or do you want the newest Tesla, which is really sexy and fast, but and it's more expensive.
I know what I would choose. Like if it was me, I would definitely go the Tesla over the Toyota.
Yeah, I know.
And I would hope that the government would back me in that. Yeah, it's hard.
Yeah,
I know.
But Camry still works.
It still works. Yeah. Okay. So, okay, let's talk about, so you have a relapsed patient. Do they need a new biopsy or new genetic testing as well?
Okay, so that depends on what your status is. So back in the days when all we had was chemotherapy, and we're repeating chemotherapy again and again and again and again for a given patient, I would say that it's important to retest for the P53. So if you have chemotherapy and you relapse and you're about to retreat with chemotherapy, I would say it's important to retest for P53 because that can emerge over time. So the more chemotherapy someone's had, the more likely the P53 will appear. And if you find it, this means that chemotherapy is no longer suitable. It's probably slightly less relevant these days because we would typically expose our patient to chemotherapy only once in general. And then when they relapse, we tend to then go to the targeted agents. And then we get targeted agent number 1. And then when that stops working, we go to targeted agent number 2. And those targeted agents on the whole bypasses the problem of P53. If you have P53, it's still not quite as good as someone who doesn't have it. But in general, you respond pretty well to targeted agents. So I think if you're about to have a targeted agent and, it's reasonable to just go straight onto it and not retest. But, if you have a research interest like in CLL, like I do, and you really want to know blow by blow what's going on in detail, then we do tend to retest.
So I think you just touched on my next question was if patients do relapse, what are their treatment options? But you said you just go from the chemo to the targeted therapy and then you move on and on.
Correct. So you tend to go to the targeted agent. Some patients repeat chemotherapy is possible if that's the patient's preference. And that's because some patients have had, let's say, an incredible response to chemotherapy. Some people have chemotherapy and they relapse 10 years later. And then you say, well, you can get chemotherapy again. You probably get another 5 years, or you can get a tablet which you have to take every day for the rest of your life. Some patients go, well, give me chemotherapy again. That worked well last time.
And I suppose that's the important side of having the patient in on that discussion and what suits them best in their lifestyle as well, because some people might want the tablet, or some people would just want the chemotherapy and have it over and done within a couple of months and go back to normal. So that's really important to be able to have that discussion, I think, and for the patients here today to have that discussion with your doctor and keep involved and informed. Next was about clinical trials and how they access them. I think we slightly talked about this, but I'd like to maybe just even for the patients in those rural areas who have relapsed and want to get onto a clinical trial, what would be the best way for them to do that?
So most of the specialists will be very much aware of what clinical trials are available in your state. Or if they don't know the exact details, they know the person who will know what the clinical trials are available in the state. So I would say the most important thing is for you to speak up to your treating hematologist. Look, I'm interested in clinical trials. I'm interested in trying to access new medicines. Can you link me in? Am I a suitable person? And have that discussion with your local specialist. Because even if they don't have trials themselves, they know someone who does, and they know who the right person to refer is. I guess one of the questions is, I wonder if people have an understanding about what clinical trials is about in general. And a typical sort of reaction to a clinical trial, and there's several. Is firstly, am I a guinea pig? comes up very frequently. It's a real shame because I do like guinea pigs. They're very nice animals. I had them as a pet when I was a child. It's a shame that they and then the other question is, am I going to get placebo? Am I going to get something that's ineffective? So clinical trials are where we get access to new treatments, or we use combinations of new treatments in ways that, let's say, an expert like myself and my colleagues around the world sit down and think, if we have these patients and we're going to design the best treatment that we think is for that patient, how do we advance it? We'll design a clinical trial around that. And that might be a new drug, or that might be a new combination of drugs. So really, when you go on a clinical trial, the design has been thought of very carefully by the top experts in the field. And we think that, our best guess is that the way to make things better from what we have right now is to do this, okay? So in clinical trials, usually people don't get inferior treatment. And usually they get treatment that's better than what is available on standard. Now, there's some clinical trials where the drug is very new and we don't know what the exact dosage is for the drug just yet, and we don't even know the side effect profile very well. Those are typically clinical trials that are for patients where the normal things have failed and there's really no other treatment options. And we select those drugs very carefully. We only select them if we know that it is likely to work, or it shows good promise in the testing in animals and in the test tube. And those patients go into there's a phase 1 clinical trial where patients will start often with no other good treatment options. We start at a very low dose, and then we watch out for side effects, and then the dose will gradually increase as we gain more and more confidence with the drug. Some drugs show incredible promise in the phase 1 section. So, for example, ibrutinib, which I mentioned before, our jaws dropped when we saw the results of ibrutinib in phase 1. Patients who are otherwise destined to die basically go out of wheelchairs and go back to normal life, and they thought, oh my gosh, what is this? And then other drugs, even in phase 1, shows that it probably doesn't work, and then that drug doesn't get developed any further. For the drugs that show good promise in phase 1, so we find the right dosage, we know what the side effects are, and we think this is a really good drug going forward, we do a phase 2 study where patients, we basically use the same dose that we optimized from phase 1, and we treat a whole bunch of more patients with this to just get more experience. Let's treat 100, 200 patients, let's get some experience, make sure that what we're seeing in phase 1 is correct. And then if it comes through phase 2 okay, then you go into phase 3, which is like heavyweight champion of the world. So phase 3 is basically where you come on and you got a new challenger, you get this new drug, it looks really promising, and then you've got the old established standard, the best of the best. And then you compare head to head in a randomized fashion where half the patients are assigned randomly, by chance, to one group, and the other half are assigned to the other group. And we basically let the results tell us whether the new drug is better than the best of what we already have. So in joining a phase 3 study, there's a random section. So because there's a risk, you're so randomly assigned to one arm or the other, but the worst that you can get is the best of what we already have. So
it's still good.
It's still good, precisely. So,
and that's it.
We're not going to put you on placebo. It's just, it is not ethical to put someone on something that we don't think is going to work.
And I suppose if there's no other options, or this is one of the better options for them, then I think, it's something definitely to be considered from patients. And I think we talked about them accessing it from the rural areas. So it's just not as easy as just going down once. It's something that they'd have to think about long term.
Yeah.
Okay. Can you explain the undetectable minimal residual disease and its significance with CLL?
Okay. So in the CLL world, we are a bit of a victim of our own success. Okay. If we go back 30 years and the medications we give, they don't work very well. So your blood count will go from really high to moderately high. And then you say, all right, things worked well. We've killed off some leukemia cells. That's like a partial remission. And then we got really good chemotherapy like FCR, where we basically wiped out everything in the blood and the blood's normal, the scans are normal. Let's look in the bone marrow. And sometimes even the bone marrow is normal, at least by using a microscope and using a human eye to count. And that's what we call a complete remission, which means that, we've got the cells down to a stage where we can't find any and any cancer cell using our eyeballs. Now, minimal residual disease takes it to the next notch. Our treatment is so good these days that we can get the cells down to such a low level that not only can we not find them with our eyeballs, but when we use our best test, like a flow cytometry test, which is an automated test, and we look at 3 million cells in there, that we still can't find a cancer cell. So minimal residual negativity means exactly that. It means that there is no minimal residual disease left. Minimal because this is disease that we can't see with our eyeballs. We have to use a special machine to find it. And if you can't find anything, even by those special machines, then it's called minimal residual disease negative remission. And I think common sense would tell you that if you had such a great response in your cancer, that even our best machines, after looking at 3-4 million cells, struggle to find any CLL cells in you, then you're going to do very well. Whereas if you have a fairly lukewarm response where you might just have a slight 4 in your blood count, but you still see CLL cells everywhere in your blood, even by the normal eyeball, then you're not going to do so well. So that's why minimal residual disease negativity, or MRD negativity, is now becoming a quite important endpoint in some of our best treatments, because we're trying to push the envelope to get to a stage where patients have basically no detectable leukemia left in their body.
And are those tests done routinely on everyone after treatment?
No, unfortunately not. So MRD testing does require a special blend of flow cytometry, which is not routinely available. So if you do a clinical trial, or you're a very, very specialized center, we can do those tests. And, it probably doesn't really change the outcome, because it just tells us what a good job we've done with the treatment, but it doesn't dictate how much treatment we give someone. So,
it's hard for patients, I think, because they would like to know, the patients, they want to know, if I have that little bit left over that you can still see, there's that chance that it's going to come back a little bit sooner than say there isn't any. And can they ask for it if they want it?
They can ask, but you're going to find it hard to do it in most laboratories. So it could be quite complex, especially if you're outside of a major center, essentially. And even many major centers can't do this test. I think the big yardstick really is whether you've cleared your bone marrow. I think you've cleared your bone marrow by human eyes microscopy looking at the slide, then that is the big step. That's already the big step to doing really well. The minimal residual disease is amongst those patients where we can't find anything with our eyeball. There'll be a subgroup where we can't find anything at all, anything with our best machines, and they do even better. But the big step is having cleared your bone marrow.
Okay. All right then. Thank you for that. Okay, so we're sort of getting to the end. So what tips do you have for patients who are watch and wait and struggling to feel like they aren't doing anything when they have a cancer?
What tips do you have? Well,
it's probably one of the things. So before you came on, we had 3 videos, and a lot of the patients, it's a mental struggle. And when I speak to patients, a lot of patients are, their family and friends say to them, "You've got cancer, why aren't you having treatment?" And it just puts that anxiety in them as to why they haven't started something when they think that they should have.
I would say it's probably one of my most discussed topics, actually, with my patients. It's really hard. I mean, to the first thing to acknowledge is that it's really, really hard. There's very few things worse than uncertainty in life in terms of psychology. And knowing that you've got cancer and we're not doing anything about it is frustrating. So we know that starting treatment early doesn't improve things. So the experiment has been done over and over and over again in CLL. In the past, we've randomly assigned patients to start in treatment early, as opposed to just waiting and watching until the treatment needs to be treated. And every time we've done the experiment, patients who start treatment early often do worse. They never do better. So we know that starting treatment early just subjects patients to, the side effects of treatment earlier and doesn't make them live any longer. Okay, that's for sure. About half the patients diagnosed with CLL never require treatment. So, although it's a mental worry that you have it brewing in the background, about half the patients will actually never require anything done. So if you get treatment right now, you're going to get treatment that you don't actually need to have. You might just end up dying of old age, of other things, and not ever having leukemia treated. And treatment improves on a year-by-year basis. So what I use today is different from 2 years ago, very different from what I used 10 years ago. If I don't need a computer today and I need a computer in 5 years time, I'm not going to go out there and buy a computer today, because in 5 years time, the computer is going to be so much better when I truly need it. And the same thing with treatment. You don't want to get the inferior treatment that we get today that will be superseded by better treatment in 5 or 6 years time. If, let's say, you get to a stage where you require treatment. And so I think those are the things that people need to keep in mind, that, it is really frustrating to watch and wait. But even if we give you the most potent chemotherapy today, we're not going to get rid of it. It's going to be stuck with us for long term. Starting treatment early doesn't make people live any longer. It just exposes you to side effects and the inferior technology that we have today as opposed to what we can get tomorrow. And there's a really good chance that, for our average patient with CLL, that they're going to live a normal life and die of something else and have to see the hematologist or the doctor every 3 months for blood test examination. But that's the extent of their illness.
Yeah, and I suppose that comes true when you're looking at relapse. So you've had your treatment, and then we can get you into that remission for quite some time, and in the hope that those new drugs coming through will be far superior again to the ones you just had.
Yep.
Okay, so if patients listening to the session have unmet needs or questions, concerns about their treatment decisions or advice from their doctor, what would you advise them about?
So, almost every hematologist, oncologist, general doctor I know are actually quite knowledgeable in CLL, and if they haven't read the latest issue of the New England Journal, they would have some awareness about what's out there or who they can ask. So I would be very candid about discussing your concerns with your treating specialist. I think it's important that that patient have open communication. And obviously you can seek information from groups like Lymphoma Australia. You can seek groups from like other patients. But I think the most important contact in your life is actually your local doctor. You need to feel that your specialist and you have a trusting relationship, that you have got faith in each other. And if not, then you might need to find someone that you feel that rapport with, because it's a long-term relationship when you're CLL, and you need to feel that you have got faith in your doctor, and you need to be able to feel that you have a ability to speak up if you've got any concerns. Because certainly I wouldn't want any of my patients to hide their unspoken concerns with me, and go and find information often in areas that are sometimes of dubious validity. So often people get piece of information that are just not right. And we live in the information age, which is amazing. Okay. But the dangerous thing about the internet is anyone who's got a keyboard and an internet connection can put out information out there that looks really reliable.
It's not. And I think you've just touched on something really important, because it's something that we advocate for a lot for our patients, is if you don't feel comfortable with your doctor, or you're not happy with how they even speak to you, there's always other options out there for you. It's a little bit harder, I suppose, in those rural areas, but I think if you're having difficulties like that, we can always try and help you find another one. Not that but there will be somebody out there who's a great doctor for you. And I've often seen that in my career, where some people aren't suited to their doctors, they change and they completely love it, and they've just got a different outlook on their actual treatment. Okay, so the last thing that has had a huge effect on the CLL community is COVID. It's big, and it has impacted them a lot. And we already have a couple of questions in the chat, in the Q&A, about the COVID vaccine and it for CLL patients. So how has COVID affected the CLL community?
It's big. Right from the start, there were indications that patients with CLL tend to have a much higher risk of dying from COVID. So the initial data that came through the US and Europe were that about 1 in 3 patients with CLL will actually end up dying of COVID. Now, that's a really high number, and that seems to include both patients who have had chemotherapy, where the immune system may be compromised by chemotherapy, as well as patients who's never been treated. So that really frightened us. Now, I have to say that, in our limited experience, we saw exactly the same thing. I lost quite a number of patients at the start to COVID. That almost never happens anymore. Like almost most of my patients have got mild disease and they don't die. And I think the major reason for that is vaccines. So almost all my patients are either triple or quadruple vaxxed. And I think that has a major impact on why they don't get sick anymore. Of course, we've got better access to antivirals now. So patients CLL, if they do catch COVID, are defined as being immunosuppressed, so they get antiviral drugs to help them recover faster. But I think it's all about the vaccines. And patients with CLL don't respond as well to the vaccine as a normal person would. So the protection is not as good as a normal person, but there's still good protection. So patients with CLL must get the vaccine and should go out there and continue to keep up the boosters as per the recommendations. There is something called EvaShield as well, which is available in some states. And this is a pre-manufactured antibody that will give an extra layer of protection on top of the vaccine. And I advocate it to all my patients who are eligible for it, because I think, you can't get enough protection from COVID. But the reality is that, at the start of the epidemic, I lost like patients, even patients who were very well to COVID. And I can't think of a single patient last year who's died from COVID under my care, and I've got a lot of them.
That's great. I mean, that is good, and it's promising news. And I think from what I heard the other day for the CLL community, the effectiveness of the vaccines improved for them the more they had. Was that right? Correct. So when you get more and more doses of vaccine, no matter which type you get, your antibody levels get higher. Now, you might say with Omicron and BA4 and BA5, the antibodies don't bind as well to the virus. But you compensate for that by getting more and more vaccines, because every time you get vaccine, the levels of antibody gets higher. And it gets so high that even the binding is not perfect. It's still got pretty good binding. Okay. As I think that was one of the questions in the Q&A, is if CLL patients have had the 5th COVID vaccine, should they seek the 6th 4 months later, or is it not known if this is the case? I don't know if that's available just yet. The 6th.
I don't think that's available.
No, I don't think it's been approved yet. I'm sure at some point it probably will be, but not just yet. All righty. So I think, and has your treatment for CLL patients changed during the COVID era? I suppose things are probably getting a little bit more normal now, but during lockdowns.
We've probably just pushed back a bit our patients, and we've tried to avoid the use of rituximab in some cases where where there's an option to delay, just because it can impair the vaccine response.
Yeah. Okay. All right. So just any take-home tips from the end, like at the end of this session, anything that you want the patients to know, really?
No, I think it's good that you seek information, but like I said, I think you need to be comfortable with your doctor, and trust is important. And thanks for having me on.
Thank you. All right. Sorry, I have a couple more questions. Do you have to run away right now? I think you have to go shortly. But
I've got a patient in 8 minutes, but that's okay.
Yeah, I have 8 more minutes. Okay. If a patient was on fixed term treatment of a combination of BCL2 inhibitors and BTK inhibitors, would you expect to see the minimal residual disease after the treatment?
About 75% of patients on the combination of the best two, BTK and BCL2 inhibitor, would clear a minimal residual disease, which means about 25% are still positive at the end of the treatment.
Okay.
So I mean, the reality is that all of these patients will have had a good response. Okay, and as I explained to my patient, the question is, have you got an A in your exam, or have you got an A+? So A is like just a standard patient, complete remission, but minimal disease positive, and the A+ are people who are MRD negative. So I wouldn't be disappointed. An A is still a really good mark. We just need to watch it a bit more carefully.
Okay. And I suppose then so these are coming from patients, sorry. It says if it wasn't reached, would this mean the patient would be more likely to relapse quicker? And if relapse occurs, could the BCL2 inhibitors and BTK inhibitors be used again for treatment, or would another treatment option be required? I think we sort of touched on that.
Yeah. I mean, yes, if you're MRD positive, you're probably going to relapse a little bit sooner. But the reason, and something that we didn't touch on, is that most of these drugs, the reason for combining these drugs together, and these are on clinical trials, okay, by the way, they're not available in PBS, is that we can give the drug and then stop, and then let the body recover before, and then hopefully in the future we can retreat. Because the problem with continuing these drugs long term is that the leukemia gets used to it and develops resistance. So we're hoping by pausing it and then stopping, that the leukemia, even if it regrows, will not be resistant to the drug, and we can hit them again.
Yeah, okay. Thank you. So on completion of obinutuzumab and venetoclax, 12-month treatment for CLL, how important is a bone marrow biopsy to tell us that a normal blood test cannot?
It doesn't change your decision making in terms of you still stop treatment at the end of 12 months and you still get monitored. Okay, it comes down to whether do you want to know whether you've got the A+ or not. If you do a bone marrow, then you know that you've had, and you see that you had good response, then you know you've got with a reassurance. You haven't had a bone marrow, but you just don't know. But to be honest, if you have a normal blood count and your examination is normal, you're likely to do very well. So the bone marrow doesn't add additional information to change your treatment. It gives you just an idea about how well you've done for your own peace of mind.
Okay. Gary wants to know that I had a fish chromosome analysis done and it mentions the RB1 gene loss. I can't quite seem to equate this to the usual mutations of IGHV, TP53, and 17p. What is the RB1?
It's on chromosome 13q. So if you have a loss of RB1, then you basically have a 13q deletion, which is a generally a good prognostic marker. It's one that we don't talk about very much because it doesn't change, how we manage the patient. But yeah, that's what it is.
I think there's a couple, but I will probably let you go because I really appreciate your time so far. I know we've gone over time and I know that everybody would have appreciated your time today. So thank you so much, Con, for being here.
You're welcome. All right. Enjoy the rest of World CLL Day.
Yes, and it's Lymphoma Awareness Month, so hopefully your team might have gone Lyme at the hospital.
Great. Okay. I need to go find myself a Lyme pocket square.
Okay, thank you. See you later.
Right.
So I'm sorry we couldn't get to all of your questions. I know we had gone over time with Con, so I really appreciate everybody for being here today. If anybody is struggling with the mental side of it, I'd hope that you could speak to your GP. There are there are plans that you can get to speak to specialists and get some help. If you wanted to give us a call, we could speak more about that up to the last line. At Lymphoma Australia, we do have also a lady called Carol who does some wellness coaching and guidance, which you can find on our website also, and you can sign up for that. She'll just do some one-on-one sessions with you. We're also running at the end of September a wellness webinar that includes exercise physiologists, dietitians, sleep specialists, sexologists, and Carol, our wellness lady. So if you can join us for that, you can sign up via the website. I hope that you enjoyed today's session and you have a great rest of the day. Thank you.